Hi, Dr. Raj here. And I guess I'm always excited, but I'm extremely excited today to present, some new information, some new theory about COVID-19 and really talking about the patients who go into respiratory failure. And, as my title slide states that I want to talk about something that I'm referring to as atypical ARDS. And, before just jumping into this, I was just commenting to my friends and colleagues that I think the hardest thing in the whole world right now is to talk about COVID-19 because it seems the minute you say something, the minute something leaves your mouth, something new happens or something you said gets contradicted. So, it's not easy. And, a lot of people have been putting things out on social media. A lot of people have been putting things out in a university setting. And I compliment all these people because it is really, really hard. And what were some motivations to go into this talk that I want to give today is number one, there's been new data. Of course, there's always new data about, the people who go into the medical ICU, the people who end up on the ventilator, that there has been a very, very high mortality. People are dying. And now there is a question out there saying that should we even put people with COVID-19 who develop this respiratory failure, distress, hypoxia on the ventilator? So I really feel that one reason why they may have a high mortality and have a poor survival when they're on the ventilator is because we need to think outside the box. And that maybe what we're calling this ARDS, this respiratory distress syndrome, maybe there's a different version of it. Maybe there's an atypical version of it, and maybe this could help out in those patients. Another motivation for doing this video is because I think about a week ago, I put out COVID-19 ARDS, and I put that out there to talk about the typical ARDS, the traditional ARDS, and there are patients with COVID-19 that develop this. But of course, this is maybe one of the reasons why when we are using ARDS, the classic typical protocols, maybe some of these patients aren't doing well. So very excited about talking about this today. And so as the title says, COVID-19 atypical ARDS, is this a new disease? So I hope you all enjoy this. And this is kind of like a continuation, a part 2 of my initial video where I talk about the typical ARDS. And if you want to watch that, please go to my website. I'm sure you can look it up, but let's get started. So when we talk about COVID-19 in general, I think the big thing is that there's just a wide spectrum of disease and illness. And anytime I go on a media platform or talk to my residents or fellows, I always say that COVID-19 is a heterogeneous disease, meaning that, what people see in one part of the country is different than the next, the East Coast, the West Coast, or even within the same state, or even within New York itself. And unfortunately, many people are suffering from COVID-19 in New York. I have many friends in the different areas, different boroughs of New York. And what happens in Brooklyn is not the same in Manhattan. What happens in Manhattan is not the same in upstate or in Long Island. So it's amazing just the heterogeneity of the disease itself. So when we talk about in broad strokes, the spectrum of illness, by far, and a good thing is that a majority will have mild. And I'm going to give you some rough numbers. Once again, these numbers are always changing, but around 81% of individuals who have COVID-19 will have mild disease. Severe, which we're going to define as having some shortness of breath, some hypoxia, and, I say significant infiltrates, but, I'm going to spend some time today mentioning that not everyone needs to get a chest x-ray. Not everyone needs to get a CT scan. And the main reason why is exposing other individuals to COVID-19. And during my presentation, you'll see that in the ICU, we do tend to get a lot of x-rays and we are exposing other people. So when we talk about severe, this is how I'm defining it. And around 14% will be severe. And critical, and that's what I really want to focus on, is that 5%. Of course, that number is small. And I want to take a time just to say is that, when we talk about this heterogeneity of disease, there are some people in the United States that really still don't believe that COVID-19 is really a disease because they don't have any in their state, in their city, in their county. And it's when you watch, the news or social media and people are like, this is the real deal, which it is. This is the critical patients that we see, that 5%. And that's where, when I see them here at USC, it is very humbling. And these are the ones that really encourage you to yell social distancing from the top of your lungs. But the critical type is going to be people with ARDS. And once again, I'm using it as a broad term. They have shock, multi-organ dysfunction. And a big thing right now is actually cardiology. And, you know, many of my very, very close friends are cardiologists. And this could be an idea about doing another video about the cardiac manifestations of COVID, but by far they develop cardiomyopathies, arrhythmias, and when we talk about the heart, that is one of the most essential organs that we need to take seriously if there's involvement. So today's presentation will be focusing on the 5%. But look at my bottom 3 bullet points. I just wanted to pound home that, you know, these numbers, they vary by geographic location. So taking it as a whole, about 40% of individuals will develop ARDS, which is why I want to talk about that. Hospitalization rates of individuals with COVID-19 could be around 20 to 30% of individuals go to the hospital in general. And the ICU admission rates is around, you know, depending on where we get our information, 5% to around 11.5%. So focusing on the ill, the severely ill, people going in the ICU, what are going to be the risk factors that will potentially make you, unfortunately, a candidate for a higher level of care in the ICU? Of course, my first bullet point is going to be age. Greater than 65 years seems to be a standard cutoff in many literatures. Serious underlying medical conditions, of course, lung disease, and I really can't emphasize asthma. We've seen so much about that. And why is asthma important? Because the whole controversy about giving steroids, I could tell you one thing: if someone's asthma is being flared up by COVID-19, I mean, that is definitely going to be an individual you want to give steroids to. But this also raises up, when we hear stories about young individuals who have COVID-19, well, you could think about them being asthmatics, and maybe that was the underlying disease that tipped them over to having severe lung disease. You know, cardiovascular disease, and I put examples: coronary artery disease is CAD, congestive heart failure, and even hypertension. Why did I want to put hypertension there? Is that if you were just to say, raise your hand if you know someone with hypertension, well, that's everyone. So more people at risk than what you think. And of course, not to veer away, a big part about this are using drugs like ACE inhibitors and Ards. And maybe we can get, like I said, that cardiac lecture, maybe bring my friend who's a cardiologist to comment on, hey, what about the role of starting ACEs and Ards, which sounds like a bad idea right now in people who need it for their heart disease or high blood pressure. When we talk about other things, severe obesity, we know that unfortunately obesity is a risk factor around the world when we talk about just, you know, generalized health. But being obese, I put a body mass index greater than 40 would put you at a higher risk for severe disease. Diabetes, one of the most common and severe risk factors for heart disease. Chronic kidney disease and even liver disease are all going to be risk factors when we talk about people having a severe course going to the ICU. Then I wanted to mention people who have immunosuppression. And those are people who are going to be people with sarcoid, people with rheumatoid arthritis, lupus, scleroderma. I could go on and on and on. Inflammatory bowel disease, being on medications like steroids, like TNF inhibitors that will suppress your immune system. And I think maybe this is time to get a rheumatologist to come in and talk about what do we do when we talk about this immunosuppression during this time when you have COVID-19. And just to say one thing, chances are we're going to say, don't stop your medications, but be careful when starting. And of course, people with HIV. And the last bullet point that you see is going to be people with a high SOFA score and a D-dimer on admission. So SOFA score is going to be something I traditionally talk about when I talk about, well, what is the criteria for sepsis? If you look at the right side of your screen, I put some of the SOFA score there. And maybe if you so far like this video, maybe please contact me and say, hey, can you do a whole lecture on sepsis? And let's talk about what the SOFA score is. But when we talk about the sepsis 3 guidelines, when we talk about sepsis, it's going to be infection, as you can see here, plus a change in something called the SOFA score. I think we need to be familiar with it now because we're using the SOFA score more and more during this COVID-19 pandemic to help determine well, how severe are you? And also we're using this in terms of palliative care as far as allocating and triaging people based upon severity of illness. But a SOFA score includes parameters that includes the lung, a PF ratio. Cardiovascular, is your blood pressure low? Is your mean arterial pressure going to be less than 65? The bone marrow, looking at low platelets. Your mental status using a Glasgow Coma scale. Your liver functioning using a bilirubin level that, is it elevated? And looking at the kidneys, looking at serum creatinine, or looking at urine output itself. And based upon a score, that will say that the higher score you have, the more severe illness you have, as well as an elevated D-dimer on admission to the hospital. So what are some laboratory features that are also associated with a poor outcome when we talk about COVID-19? And I just put some of the ones that we're using in our hospital that other doctors and colleagues have been using in other hospitals throughout the country. I think one of the most important ones is lymphopenia. And that's why when we order a CBC now, I do order a CBC with a differential. And you want the differential to look for the lymphopenia, and as the patient hopefully is improving, the lymphopenia will actually improve. And not to jump ahead of myself, but one of the things that's going to be the cause of all the problems with people with severe COVID-19 is this, inflammatory response, is this cytokine response. And we know that this increase in interleukins and cytokines is going to be inversely related to the lymphopenia. The worse the lymphopenia, the higher that cytokine response. Also, elevated liver enzymes, which is maybe one of the reasons why people who have liver disease, cirrhosis, are going to be at a higher risk. An elevated lactate dehydrogenase, we call an LDH, though non-specific, is a marker that we like to follow. Elevated inflammatory markers, C-reactive protein can be trended, and of course, ferritin. And when we talk about elevated ferritin levels, I have managed patients personally who had ferritins in the thousands, and that's a very important inflammatory marker to look at. Elevated D-dimer. And one thing I wanted to mention is the last bullet point. We have noticed, at least at USC, coagulation dysfunction. And one of the things that's interesting is that, many people with sepsis will have what we call disseminated intravascular coagulation, DIC. And historically, the fibrinogen level in these patients are going to be low. But looking at patients who have severe COVID-19, that fibrinogen is elevated, which is very strange. And so right below here, I put in actually a diagram because some people, we talk about things so commonly that people may forget, is that what is fibrinogen? Well, fibrinogen gets turned into fibrin, and it does that through a protein called thrombin. And when do we have a release of thrombin is when you have vessel injury. And thrombin also activates platelet activation, platelet aggregation to help, with that vessel injury. And this could be very important. Why? Is because when we're talking about the hypoxia that may be occurring in these patients, it could be at the vascular level. There could be this microvascular thrombosis. And because of that, that's going to be preventing blood flow to maybe some of these good alveoli. But still, the fibrinogen should actually be lower in these cases, but it's very interesting that it is elevated. So this is probably one of my favorite slides that I have on this presentation. What is the mechanism of the patient being hypoxic? So when we talk about this, these are the patients who go to the medical ICU, and unfortunately, they're going to be on the ventilator. Why are they on the ventilator? Because they have ARDS. And notice how I called it ARDS-like. I think many of us around the country are very, are walking on eggshells by calling it ARDS because of the high mortality rate. And some of the classic things we see in ARDS, we're not seeing in these patients. So when we have this ARDS-like picture, sure, it probably happens, greater than a week. And I'm going to show you a table in a few slides of what the time course is. And one thing that's interesting is that many of the doctors I've been talking to said that people who develop this ARDS-like picture they don't always have bilateral diffuse disease, which is the classic thing that we commonly see in ARDS. So I'm going to put this ARDS into two subtypes. Now, these are not official words and terminology that we're using, and I put down some amazing doctors who actually did publish some, initial data about this on the bottom of my slides to acknowledge all the amazing minds that are out there who are thinking about this. So when we talk about some of the two subtypes, the traditional type is atypical ARDS. I'm going to call that number one. The other type will be atypical ARDS, and that's going to be subtype number two. So let's talk about the classic one. And I'm going to say that please refer to my video that I recently put out, and maybe I'll have some kind of link to actually jump to that if you want to talk about classic ARDS. And when we talk about classic ARDS, it is low compliance, meaning that the lungs are very, very, very stiff. And the reason why this was brought to my attention, and I've actually seen this in my patients, is because one of the things that we check in patients who have ARDS is a plateau pressure. So if you could refer to the top of the screen over here, when we talk about terminologies, peak and plateau pressures, what are they? Well, I have another video that you could watch about this, but when you're on the ventilator, and you could check a peak pressure. And if you have a elevated peak pressure, you have to ask the question, well, why is it elevated? And quite commonly what we check is a plateau, which is an end inspiratory pause. So literally there's a button on your ventilator that you or your respiratory therapist can do. It's a valve that closes at the end of inspiration, and it measures pressure. So you get a plateau pressure. And if you have an elevated peak and an elevated plateau pressure, it's a compliance issue. And just to mention over here, and after I let go of my plateau pressure, you come down to usually your baseline unless I have something here called PEEP, positive end expiratory pressure. And in this case, this patient probably has somewhat maybe 5 of PEEP, so it comes down to the PEEP. So when we have our traditional ARDS, very poorly compliant lungs with a very, very high plateau pressure. And in a physiological sense, we see a lot of right to left shunting of blood. People ask why? Because if you're very hypoxic, like you will be in ARDS, you get something called hypoxic vasoconstriction. And as you constrict these pulmonary capillaries and pulmonary arteries, all the pressure is going to back up. Back up where? To the right ventricle, to the right atrium, and you may get some shunting of blood if you have maybe an undiagnosed patent foramen ovale or some kind of anatomical connection between the right and left side of the heart. What else can force you to have that shunting is just being on positive pressure ventilation, having lots of PEEP. If you ask why, when you distend these alveoli, they're going to be squishing these pulmonary capillaries, and once again, shunting blood back towards the right side of the heart. When we talk about the typical ARDS, these are the ones that really, they're recruitable alveoli, because once again, that ARDS traditionally, the typical one is a heterogeneous lung disease, good lung and bad lung, good alveoli, bad alveoli. And as I always say, the alveoli in classic ARDS is shriveled up, and you give PEEP to open it up. So they usually respond to PEEP, and usually with these people with typical ARDS, we literally try to crank up the PEEP, and of course we titrate the PEEP to the plateau pressures. But what have we been seeing in our medical ICU with many patients is something called this atypical ARDS. And the first thing that was pointed out to me by my respiratory therapist, by many of my partners and colleagues throughout the country, is that when they were checking these plateau pressures, they were normal, which goes totally against what I think about with classic typical ARDS, that very non-compliant stiff lung. So right there, that raises a question mark, is this even ARDS to begin with if you have a normal to high compliance? And how do I know that? You check a plateau pressure and it's what? Normal. So one thing that we noticed in here is that maybe that there is a low VQ areas that are opposite traditional thinking. usually when we think of typical ARDS, that's what we call shunt-like physiology. Problem is with the ventilation, but there's no problem with what? Perfusion. But when we talk about this atypical ARDS, maybe the problem here is more on the Q, which stands for perfusion. And why are they not perfusing? Well, let's go back to this slide right here and talk about what's happening at the vessel level. Maybe they're having clotting at the vessel level because of this coagulation dysfunction. So that's why maybe they're hypoxic, because you're not having delivery of that blood flow. So instead of having something that we call shunt-like physiology in typical ARDS, maybe they're having alveolar dead space. And what is alveolar dead space? The alveoli is wonderful, but what's the problem is not getting perfusion to that good alveoli. So based upon this, we've noticed that these individuals with this atypical ARDS have a very limited PEEP response. So going back to here, positive and expiratory pressure is a button on the ventilator that you could turn up that is like a valve that closes at the end of expiration, and it keeps alveoli distended. But what you've been noticing is that when you crank up the PEEP, it really doesn't improve their hypoxia. And in fact, you get all this hemodynamic cardiovascular collapse. What do you mean? Is that as you crank up the PEEP, what's happening to blood pressure? It's going down and down and down because of the fact that everything is backing up. You're not getting any preload to the left ventricle. You're not getting cardiac output, and it's going to drop your blood pressure. So what happens is we start giving them what? Fluids and pressors. And we know in general that you want to keep these patients who have ARDS-like presentations on the negative to even side when it comes to fluid balance. So we're having this very limited PEEP response. So what are we doing instead is, or at the same time, is that we've noticed that doing this prone position has actually had benefit in these atypical patients. Not to say we don't do proning in typical, but we've noticed that, you know, we are using PEEP, but not a lot of it, but we're putting them in the prone position. And maybe the main reason why we're getting a good response with the prone positioning in these individuals is because you're getting better perfusion to some of the alveoli, really trying to improve that blood flow. So when I think about this, you know, is that there are two different types of ARDS, and it's really important because one of my first things I said was the mortality is so high in patients who are on the ventilator going to the ICU. And this is going to be maybe one of the reasons that we need to look into, that hopefully more physicians and will start reporting their experiences about this typical and atypical ARDS. But that's going to be one of the things I was very excited to talk about that I've seen clinically and that many doctors around the country have been telling me. So I put this here just to, once again, talk about the classic typical definition of ARDS. And what do we say? It's acute, usually less than a week. We say usually there's bilateral imaging. We define it as a PF ratio less than 300, being on a minimum PEEP of 5. And of course, it can't be explained by the findings from a cardiac etiology. So please refer to my video once again when we talk about classic ARDS. I put this here because when people, what is the downside of giving a lot of PEEP? And maybe people didn't catch what I said in regards to we're getting the bad effects of PEEP over here with the atypical ARDS when we give too much of it, is because here's a normal alveoli. And when I set PEEP on my ventilator, what happens to the alveoli? It distends. Auto PEEP, now that's something that is different. It's a different talk. You know what I mean? There are people who develop this horrible thing called auto PEEP. And if you do want me to talk about it, please let me know. I'll love to have a different presentation on it. But you can imagine as you give more and more and more PEEP, these alveoli distend. And what happens? It pushes on the capillaries, preventing blood return going back to the left side of the heart, causing you to have that drop in blood pressure. And the worst part is that we start giving more and more fluids, which we don't want to do in people with COVID and ARDS-like presentation. So I wanted to talk even more at the cellular level about what's going on that's causing this hypoxemia, what's initiating this ARDS-like presentation. And a lot of it is based upon something called this cytokine response and hypercoagulability. And once again, I think that everyone, including myself, needed a little refresher on terminology, because I think we say these words so fast. So what is the difference between a cytokine and an interleukin? So I put this here because I thought it was the most basic way. Cytokines are a very broad term. It's a number of substances, including interferons, interleukins, growth factors. They're secreted by certain cells of the immune system, and they have effect on other cells, you know? So it's a broad term. When we talk about interleukins, this is a subclass of cytokines, and they're produced by leukocytes. They're produced by WBCs, white blood cells, and hence the word interleukins, inter meaning they interact with leukins, leukocytes to interact with interleukins. And their main job is regulating the immune response. So when we talk about reading journal articles and talking to other individuals, they will say that the big part is a cytokine response, which are all these different things. But we're noticing that specific interleukins like IL-6, IL-10, tumor necrosis factor alpha have been increased. And as I mentioned earlier, that this cytokine response really increases as your lymphocyte count becomes lower and lower and lower, and which is why we need to get that CBC with differential up front. There tend to be a reduction in when we talk about IFNG, and when we talk about other things that could be increased, there are things such as interleukin 2, IL-7, GCSF, many things can be increased. And when we put all these out there, some of these are going to be very important when we talk about basic science research, when we talk about what are going to be the next drugs out there. But the thing I wanted to focus on the most today is going to be what are we using clinically? And what are we using clinically is IL-6. And bear with me and we'll talk about that shortly. Another big part about the pathophysiology beyond this cytokine response is this hypercoagulability. And I mentioned that earlier when we talked about what's causing the hypoxia and ARDS, is that at the vessel level, you could have inflammation preventing blood flow. These patients are very prone to have clotting both in the vein and the artery. We have been having many reports of these individuals getting pulmonary embolisms and deep vein thrombosis. And I put this here, and this could be another talk, is, in patients who have, COVID-19, and unfortunately their heart stops and they're having a code, should we be giving these individuals thrombolytics during the code if you can't resuscitate them because of the fact that they're so hypercoagulable? And that could lead to another talk, which is, should we even coding these patients to begin with? And that sounds horrible, but as you talk to your colleagues in critical care and talk to palliative care, the big thing is coding patients who have COVID-19, because you're going to be, many of them have poor prognosis to begin with. We'll be risking so many people and individuals by coding and doing CPR in these patients. And this is something that's discussed. And some hospitals have a code policy about, do we even code these patients? So that, no matter how we take this talk, there are so many question marks and controversial topics when we talk about COVID-19 and people who are in the ICU and serious disease. So what are going to be some of the criteria for an ICU admission and being on the ventilator? I just put the broadest things here because, my talks can really go on for 4 hours. I really wanted to put the highest yield things. If you're hemodynamically unstable, you have multi-organ dysfunction, if you have worsening hypoxia, or if you're on increasing oxygen requirements, if you're on the floor on 6 liters of nasal cannula, or if you're on the high flow with a combination of at least 30 liters per minute with an FaO2 of 60% or greater, hey, maybe this is something that needs to be evaluated by the COVID ICU team. I put a picture here showing what a high flow nasal cannula looks like. So this is my favorite slide. And when we talk about this slide, I, actually got this information from the Journal of Heart and Lung Transplant that came out in March 2020. And this is actually one of the first clinical stagings proposed when we talk about COVID-19. And it's just amazing. So we talk about severity of illness on the y-axis, time course on the x-axis, and we're dividing COVID-19 infection into 3 main stages. Stage 1, which is the early infection, stage 2, which will be divided into 2A and 2B, and stage 3, which is this hyperinflammation phase. And let's kind of walk through this. So what happens initially is going to be the viral response. So this is what we're telling 80% of society. It's going to have the mild disease. What are we looking for, everyone? I have cough. I'm having fevers. I'm having some shortness of breath. This is going to be that initial viral response. Some mild constitutional symptoms. I mean, the cough could be dry. There is some data about people developing diarrhea. You could have headaches. Of course, these are very, very non-specific. I mean, if we were to order labs at this time, you will start becoming a little lymphopenic. Your prothrombin time starts to increase, talking about that dysregulation of the coagulation system. You could have mild inflammation, elevation of inflammatory markers like D-dimers and LDH. Now, it's during this phase where, well, maybe you could start giving these individuals things like hydroxychloroquine. And notice how I did leave out, azithromycin at this phase because of the fact that, when we talk about azithromycin by itself, giving it for a mild infection with COVID-19, I believe that the risks of giving so many things that have side effects, including something called prolongation of the QT interval, will outweigh the benefits. But I do believe at this phase, using things like hydroxychloroquine may have some benefit. And once again, no matter what drug you talk about, the answer is they're all hopefully promising. The limitations, once again, I have other videos on this, is going to be when we incorporate biostatistics and epidemiology. But, this is where doing things like a hydroxychloroquine in the earlier stages may have some benefit. Now, as this goes on, it goes to the pulmonary phase, hence I'm the pulmonologist, and this is where we talk about, well, where are you going to go in a hospital, to the floor or to the medical ICU? And what happens during this phase is you have worsening shortness of breath. If I were to check what we call PF ratio, it's getting worse. You're going to see, in some cases, more abnormal imaging on chest X-ray and CTs. And let me just take a step back and say, when we talk about imaging, that you could have a normal chest X-ray and still have COVID-19. You could have an abnormal chest X-ray that you insist is COVID-19 and it's not. So there really isn't a classic finding that we have, even though when we talk about CT scans, I think many people will agree that we see bilateral ground glass opacities, even some what we call crazy paving. This is a CT radiology terminology that we see, in the periphery and sometimes at the bases too. But then right here, notice how the viral response is causing a lot of the problems, but right around phase 2, it's now the host inflammatory response. And it's during this host inflammatory response where you're getting that cytokine response, when you're getting the increase in these interleukins during this host inflammatory response. And it's really during this phase over here is when we talk about using other things in these severe patients, such as, steroids, corticosteroids. I know that we've been saying don't give steroids, but maybe during this cytokine response, during the this inflammatory phase, maybe this is where we do give steroids. And notice how I say IL-6 over here. There is an IL-6 drug called tocilizumab, which is a drug that, once again, has been used in many rheumatological diseases that we do give, especially in individuals who have diagnosed COVID-19 with elevated IL-6 levels. We will give these drugs at those times. And they're also studying many other things. So for my clinicians out there, they're studying JAK2 inhibitors that we use in rheumatoid arthritis, maybe inhibiting IL-2. We have IL-1 inhibitors out there already. So many things we're using at that time. And also, I wanted to mention a big topic right now is convalescent plasma. And I'm sure most of you know this, is that people who have COVID-19 and actually recover from their disease, we're taking their blood because it has the antibodies in the plasma and transfusing it into patients who have severe disease because they already have those antibodies. So once again, this is why we're using these things, and really a lot of benefit once we hit here in this host inflammatory phase. So I really feel this is a nice diagram showing stages, the early infection to the hyperinflammatory phase, and giving some recommendations of what we can do on the clinical side. So I wanted to say a few things about respiratory care in a non-intubated patient, is that things that we have out there is that the first overlying theme is we're going to have to accept that not everyone needs a very high oxygen saturation. I mean, sometimes these oxygen saturations are going to be in the mid 80s to high 80s, but the patients are comfortable. We don't need to crank up the FiO2. We don't need a high saturation. We could use things such as high flow nasal cannula. And I wanted to say that when we use high flow nasal cannula, you're adjusting the flow as well as the percent of the FiO2. And when the patients have this, we put an N95 mask on top of these patients to help out with the transmission. But if they're on this, of course, get the critical care team involved. They may need to go to the ICU. Once again, a big controversy here is avoiding non-invasive CPAP and BiPAP in these patients. Why? Because putting others at risk. Unfortunately, not everyone has the appropriate personal protective equipment. And when we use CPAP and BiPAP, we're going to be aerosolizing the virus, especially if they're going to be shedding. And right now, we have this low threshold to intubate these individuals. But this is why I feel this talk I'm doing right now is so timely, because what did we say? Once you're on the ventilator in the ICU, mortality is so high. And we really need to ask ourselves, are we doing the appropriate things on the ventilator to help these patients? Also, I wrote down avoid nebulizers. And I know it's tough, but when you give nebulizers, you're really increasing the spread of particles. So if possible, talk to your respiratory therapist, talk about using maybe meter dose inhalers. I know they still have to break the respiratory circuit, but that's something that is a recommendation, and we definitely want to avoid these nebulizers. So I always believe in evidence-based medicine. So this was actually from the New England Journal of Medicine that was COVID-19 in critically ill patients in the Seattle region. Remember that that's where we had our first cases. And it was a very, very good study. And there were 24 patients. I put their mean age, 63% were males. And, you know, some of the symptoms they had, 50% had fevers, 58% had diabetes, and all were admitted for hypoxic respiratory failure. And notice that 75% needed mechanical ventilators. A lot of them were on pressors. And look at the mortality between ICU day 1 and day 14, almost 50%, you know, and the reason why other people do not, you know, resuscitate. But yeah, this is why this is so timely, talking about how do we manage these patients. We have to really improve that number greatly. So I don't want to get overly detailed, but I want to give you some general principles of ICU care, being an ICU doctor. So I'm sure many of you can add to this or take away from it in some cases, and please feel free to maybe not email, but get a hold of me and let me know your thoughts, because I love making these videos. So I think one of the most important things for ICU care is identifying a dedicated staff to care for COVID-19. We do have an ICU COVID-19 team. I know many other hospitals do, and you folks are just amazing. And when I say you folks, I mean everyone, respiratory therapists and nurses, everyone who goes in the room to take care of the patient. I think the main thing is minimizing the number of the staff entering the room, and we all could work on this, especially myself. You know, this includes, from a pulmonary standpoint, limiting bronchoscopy, meaning that we don't really need to do bronchoscopy to make a diagnosis of COVID-19. There could be other indications to do it, but you need to take them individually. I think this is one of the big ones right here, is limiting chest x-rays and arterial blood gases. And it's amazing, you know, here at USC, we did a grand rounds, and, you know, the minute a patient comes to the ICU, they get a chest x-ray, we intubate them, they get another chest x-ray, they it's a central line, there's another chest x-ray, you know, we're moving the tube, there's another chest x-ray, and, you know, in one day, there could be 4 chest x-rays all of a sudden. So I'm not saying we shouldn't. We need to talk about policy in the ICU when you get these things, but being conscious about limiting x-rays because of staff coming into the room. I'm a big culprit of ordering ABGs sometimes, and I know I shouldn't. because of the fact that just because you made one change in the ventilator, you shouldn't always have to order arterial blood gases, especially if patients are going to be stable. So take them individual, but just be cognizant of doing that. I think a big thing right now is separating known or suspected COVID-19 patients from other patients. And we use that thing called cohorting, meaning that not only is it important to have a good COVID team, but the non-COVID teams, the doctors picking up the other patients, is going to be just as important. And I think one thing that we're all doing across the world and in our country is preparing for that potential surge in patients. I know that New York is having it as we speak, or it's even, maybe we're a few days away from its peak surge, depending on when this video comes out. But here in California, here in Los Angeles, that surge is going to happen in 1 or 2 weeks. So we're really trying to do our best to prepare for that. And I really want to say that really preparing for potential shortages, not only in personal protective equipment. I know everyone says that on the news and they are correct, but really talking about just medical supplies and medications, respiratory equipment, and of course, staff. And, I always say that, sure, I'm worried about, in certain cases, are we going to be short of ventilators? But what's just as important as being short of ventilators, who's going to run the ventilators? Where's my respiratory therapist and amazing ICU nurses? Those are going to be in short supply. But I really put here sedation and paralytics. And why did I put that there? Is that I'm not running out of ventilators. What I am running out of is sedation and paralytics. There's going to be a shortage because when you manage these patients on the ventilator, we definitely sedate them. And sometimes to help them be in sync with the vent, we use paralytics. And there's going to be shortage of these things. And this is where, when we talk about getting, the palliative care team involved, when we talk about triaging patients is not just who gets intubated or not. It also includes triaging who gets certain medications. And we're going to have to start thinking about these things. So my advice is, use minimal sedation as possible. Easier said than done. Try to avoid using paralytics unless absolutely necessary. And of course, this is case by case, and these are things to think about. But when we're in the ICU, we want to do monitoring. We do cardiac monitoring. I believe, they should be on telemetry. And one thing I wanted to say is that, I don't know if you know this, but when you're on telemetry monitoring, you could actually do continuous QTC interval monitoring. And why am I saying that is because the drugs, hydroxychloroquine, zithromycin, they prolongate the QTC. And instead of getting serial EKGs, you could just already have telemetry and set it up where they inform you that the QTC is widening. And remember, a prolongated QTC can lead to fatal arrhythmias, ventricular arrhythmias. Also, what is a POCUS? Point of care ultrasound. And what this means is that many of the ICU doctors and other physicians are trained in bringing in the ultrasound machine, looking at the heart, looking at for DVTs, looking for if there's a pneumothorax. And I think point of care ultrasound is going to be an amazing thing that we do in these patients. Some of the cardiac things we check are troponins, brain natriuretic peptide, D-dimers for a variety of reasons. And remember, from a recent, review of patients at Washington State, 33% of these critically ill patients develop cardiomyopathy. And of course, we do have order sets in every hospital. I'm sure your own hospital has certain order sets. Things that we will look from a inflammatory marker sense that we check serially are things like ferritin, CRP, fibrinogen, lactate dehydrogenase. And of course, if you have COVID-19, IL-6, this one is going to be the reason why we start medications like tocilizumab, which will inhibit IL-6. And of course, coagulation labs such as PT and PTT. So ICU definitely needs some supportive care. I could have made this slide very crowded and talk about this for hours, but I just put the most basic things. In general, if you're in the ICU, please watch your sedation and analgesia, especially with shortages going out there, but keep your patients comfortable. Nutritional support doesn't change. We need to feed these patients. We need to control their glucose in these patients and be careful of continuous insulin drips because of the amount of times that the nurses have to go in the room exposing themselves. So take it case by case. These patients definitely need GI and DVT prophylaxis, and they should have what's called an A to F bundle. And I don't know if many people know what an A to F bundle is, but I put it right here. And this is something that we look at every day in the medical ICU to help out with patient care. It involves the patients, the family, as well as physician and other staff. A stands for assessment of pain, B is going to be doing spontaneous awakening trials to wake them up, decrease sedation, spontaneous breathing trials to get them off the ventilator. C is going to be choice of analgesic and sedation, always reevaluating. And I'll say this, maybe by the time for extubation, maybe use a little more what we call brand name Precedex, because of the fact it doesn't suppress the respiratory drive, and many of us extubated on this, on Precedex. D, to prevent delirium, which many people get delirium, and that's a whole talk in itself. E, for early mobility and exercise. I know it's easier said than done with all the restrictions of people coming in the room. And this is the hardest part, is F, family engagement. You know, one of the saddest things now is when you come to the ICU and you're on the vent, you will be alone. There's no family that is allowed to come there for the obvious reasons. And my heart really goes out to someone who's on the ventilator, sedated, paralyzed, no family, no friends right there. We're trying our hardest to do telemedicine and patients who can do it, but it is very sad. And that's why it's so important to talk to family right away to get palliative care involved. And in some hospitals, palliative care is involved in anyone who's going to have a B COVID positive. So I'm going to be just kind of nearing the end. I want to talk about some therapeutic options for ARDS due to COVID-19. You know, when you're on the floor, the minute patients are on high flow nasal oxygen, be sure that they're also wearing an N95 mask, you know, on top of their high flow. And you want to make sure that they're in the right clinical setting. You don't want this to prevent or delay the need to intubation in certain patients. When we talk about tidal volume, many of us as critical care doctors call this lung protective strategy. And sometimes I feel that people are overly aggressive using this 4 to 6 mLs per kilogram of body weight. I mean, I understand the benefits of low tidal volumes, but maybe thinking about 6 to 8 cc's per kilogram of body weight, 8 cc's may be better tolerated in these atypical ARDS where the compliance is not such an issue. And you always want to be careful in these patients where you're just driving up the carbon dioxide on the arterial blood gas, the pH is dropping, so you want to be careful. Plateau pressures, you may want to check it to see if it's going to be a high plateau pressure, that's more of your typical ARDS, versus a normal plateau pressure, maybe we're talking about this atypical. Be careful with your PEEP, as I mentioned that the atypical ARDS may not need as much PEEP. You're definitely going to give PEEP, and in some cases that we use a, you know, a lower PEEP type protocol, and maybe this is where you want to actually do the prone position earlier in these patients. And one of my good friends said that when they do prone position in these patients, they may not titrate down the PEEP right away during the prone, because when they flip them back, they de-recruit very fast. But recruitment maneuvers, giving this 40 of PEEP for 40 seconds have very little value. So we don't do recruitment maneuvers, whether it's going to be typical or atypical ARDS. Be careful when we give paralytics because of a variety of reasons, as well as because of having shortages. And prone position really is something that we've had success, especially in these atypical ARDS patients and even the typicals. And, you know, on the floor, not even in the ICU, there are many hospitals that have protocols to put them in the prone position, a non-sedated prone position where the patients literally will turn on their stomachs. And of course, I mean, the classic data when you are on the ventilator is to be in the prone for almost 16 hours a day. You know, maybe we could readdress the role for inhaled nitric oxide, the role for inhaled prostacyclin analogs, because of the fact that maybe you want to help perfusion in these atypical ARDS patients. Fluid management mean you want to be on the even to negative side in these patients. You don't want to give standing orders or continuous fluids on these patients. You know, even if you notice a decrease in urine output, don't be too reflexive to always bolus, 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 you know? And of course, antibiotics, I wanted to mention that if you have a secondary bacterial infection, if you think there's community-acquired pneumonia, of course, you could use a third-generation cephalosporin like ceftriaxone and give azithromycin. And I don't mind giving azithromycin if you're using it for infections. Steroids are always going to be a very controversial topic. And like I said, during my presentation, if you're in that clinical stage 2, maybe that's the role for steroids. And quite commonly, when you give things like tocilizumab, we do commonly give that with steroids anyways, but that is going to be when I would use it, not, or if you have asthma or for other indications of giving steroids. And of course, you know, USC and other hospitals, we are fortunate to have ECMO. And, you know, we use one of the classic trials as many of our guidelines for using ECMO. That's the EOLIA trial, and you can look that up when we talk about ECMO in these individuals. You know, I think the last slide is the outcomes of critical ill patients are always so far been really sad. You know, we all have a good heart. We want to help patients, but we do need to establish the goals of care early. We want to establish who's the durable power of attorney, who's the primary decision maker. And like I said, getting palliative care involved is going to be very important, you know, especially, you know, in countries and states such as New York, where it's going to be to the point of triaging patients of who gets to use the ventilator, who gets to use paralytics. So having palliative care involved is very, very important. And, you know, I believe this is going to be my last slide over here. And let me just double check. It is. And I really hope you enjoyed this presentation. I took a lot of pride and time to really, you know, put all the evidence-based medicine that I can in this short period of time. Things will be changing, you know, as I always state, but, you know, everyone out there, you know, I have been sensing good things. I think the social distancing has been working. I wish everyone the best. Let me know if you like this video. I'm Dr. Raj, and literally I'm heading back to the ICU. Thanks for listening.